Good morning, all. I'm Dr. Iswariya, representing Medicine 2, presenting about Delirious. So, I am going to present a case series. First one being 55-year-old male, a known case of diabetes mellitus, presented to us with drowsiness, unable to identify his family members and slurring of speech since 5 a.m. at the morning of admission. He was started on Lasix 1 week ago for the pedal edema. On admission, he was conscious but confused, disoriented to place, person, and time. He had elevated GVP, but other systems are normal. On investigations, he was found to be hyponatremia. Serum sodium was 117 with serum osmolality of 251. Urine osmolality was found to be 305 and urine spot sodium was 44. MRI brain showed no acute infarct. Total cones were mildly elevated with predominant neutrophils. So his diagnosis was his cause of acute delirium was found to be metabolic cause, Lasix induced hyponatremia. Next, presenting 36-year-old male with no comorbidities. He presented to us with fever for 1 week, altered sensorium with irrelevant speech for 3 days. He had a history of swimming in fresh water 2 weeks ago. On presentation, he had no headache, visual abnormalities or vomiting. On examination, he was found to be tachycardic with a BP of 100/70 with a respiratory rate of 26. He was febrile on admission. He was conscious, disoriented to time, place, and person. Alert. His GCS was E4, V2, and M5. He had a neck stiffness, but other signs of of 51% and lymphocytes of 35%. His CSF glucose was 64 and protein was elevated to 129. Still, this CSF culture was found to be sterile and it was MTB negative. On progression, is CSF for acanthamoeba PCR was positive. So then we have progressed to do a culture of acanthamoeba, which was also came to be positive. MRI and CT brain showed no obvious parenchymal abnormality. So the cause for this acute delirium was found to be acute meningoencephalitis with acanthamoeba infection. The next case is 47 years old female who was a known case of depressive disorder, was started on tablet quetiapine 400 mg 11 years ago, was still on that, and type 2 diabetes mellitus. She presented to us with the instability of gait and tightening of limbs for the past 3 months, fever for the past 1 week, and irrelevant speech and reduced responsiveness for the past 3 days. She was conscious on presentation, again disoriented to time, place, and person. She was found to have dyskinesia involving both her upper limbs, rigidity in all her 4 limbs with neck stiffness present. Again, no other meningeal signs was positive. Exaggerated reflexes in both upper and lower limb. On examination, investigations, her hemoglobin was found to be 11.3 with these total counts of 4,800, predominantly neutrophils. Her serum sodium was 136 with hypokalemia, potassium of 2.7. RFTs was normal, blood culture was sterile. Her CPK was found to be 627 unit per liters. Her CSF was found to be normal and sterile, MTB negative. MRI brain showed no significant parenchymal abnormality. So her cause of acute delirium was found to be neuroleptic malignant syndrome, which was quetiapine induced. Presenting next case, female 29 years old with a known case of hypothyroidism for 2 years. She presented to us with altered behavior for 1 month, amenorrhea for 9 months, and inability to recognize her family and friends for 3 days. She was conscious, disoriented to time, place, and person, alert, afebrile. On presentation, she was vitally stable with the GCS of E4, M5, and V4. No neurological deficits was present. On examination, her hemoglobin was found to be 10.3, total counts of 11,300, predominantly neutrophils. Serum sodium was found to be 153 with a potassium of 4 and bicarbonate of 23. Other investigations, RFT, LFT was normal. Serum osmolality was 321. Urine spot osmolality was 137. On going for other investigations on endocrine, her cortisol was 9.3, ACTH was 23. So was normal, electrolytes was normal, her CRP was 120 milligram per liter at presentation. Her culture bred grew E. coli. So her cause of acute delirium was found to be urosepsis. So delirium, this is a diagnostic criteria of delirium by DSM. The presence of delirium meets when all the criteria are met. First is disturbance in attention and awareness. Disturbance should develop acutely and fluctuate in the severity. At least one additional disturbance in cognition like memory should be present. Disturbance are not better explained by pre-existing dementia. Disturbance do not occur in the context of severely reduced level of arousal or coma. Evidence of an underlying organic cause should be present. So according to CAM confusion assessment method, delirium can be delirium requires the feature of 1 and 2 or either 3 and 4. Acute change in mental status with fluctuating course, inattention, disorganized thinking, altered level of consciousness. All of our patients had met with this criteria. So to easily remember, we have a mnemonic for the etiology of delirium. I watched it. I stands for the infectious causes. W for withdrawal of alcohol, sedatives, barbiturates. A stands for acute metabolic conditions like acidosis, alkalosis, dyselectrolytemia. T stands for trauma like closed injury or hematoma. C stands for CNS in pathology like seizure, stroke, encephalitis. I stands for hypoxia. D stands for deficiencies like thiamine, niacin, B12, folate. E stands for endocrinopathies like hypothyroidism or hyperthyroidism, glucose altered levels, and adrenal. A stands for acute vascular like hypertensive crisis, arrhythmia. T stands for toxins or drugs like we had a quetiapine case. H stands for heavy metals. So how do we approach delirium? Delirium approach can be done by two methods, like the patients, based on the patient's response and based on an interviewer's observation. So we ask some questions to the patients like, do they remember what happened today? Do they remember their date of birth or their wedding date? And we look at the patient's attention span, the speech, their thinking, everything. The feature one is altered mental status. So we ask whether the patients had experienced this in the past days, like being confused, whether she don't know where she is, kind of. So we notice the patient's attention, patient's speech and thinking. The feature two is inattention. We ask them to tell the word we have told them, days of the week in the backwards, months of the year in the backwards, and we see the patients have trouble in having contact with us and they are easily distractible. So feature three is disorganized thinking. We ask the patients whether she knows what year is it, what day of the week is it, and where she is here currently. So the answer would be most likely to be illogical and they don't know what to answer. The feature four is altered level of consciousness can be checked if the patient is sleepy, stupeous, comatose, or hypervigilant. So delirium in a medical ward. Medicine 2 had 151 admissions in the past 40 days, out of which 26 patients was found to be acutely delirium. In 26, 62% were female, whereas 38% was found to be male. According to age distribution wise, 51 to 60% are found to be having a chance of highly delirious. And etiology wise, the most common etiology was septic encephalopathy, the next being metabolic and deliberate self-harm. Outcome, out of 26, 20 were found to be normal and with a good prognosis discharged, two of which were died and 2 of which were discharged with a disability and 2 of which was sent in Dharma. So the take-home, which is a common diagnosis, it can be caused by a simple diagnosis of hyponatremia or hypernatremia, or it can be caused by a rare diagnosis of acanthamoeba also. So to keep a broad set of differentials in mind and working up accordingly is required. Thank you.
Iswariya, any questions? Anand sir, you wanted to make a point for the previous. Just read. This is from Dr. Anand Zak. The previous presentation, the medicine 1 patient was a HCV, healthcare worker who became hepatitis B positive in 2000 and was diagnosed to have HCC in 2023. there is no record of immunization status. In 1993, the hospital started mandatory HB vaccination. This has clearly prevented HB transmission and complication among staff. He is one of those people who got Hep B, HCC despite these policies. The case emphasizes the need for close follow-up of those with chronic hepatitis B with LFT, ultrasound, and AFP annually, even if there is a clearance. Sure. Thank you, Aisha.